morning.
Good morning.
My name is Dr. Saha, one of the PACES candidate here today. Sir, I've been asked to examine your lungs.
Yes.
So what I'm going to do, I'll have a very good look first.
Yes.
And then feel and listen of your chest. And sometimes I need to tap on your chest. So during this procedure, if you have any of the pain and discomfort, just let me know.
No.
All right. So you don't have any pain at this moment?
Okay.
No. So yes, so during this procedure, if you feel any discomfort, just let me know. I'll stop at that moment.
Yes.
Okay, sir. So yes, my dear doctor, after entering into the room, that you need to have a very good smile is really important, and having very good greetings like the good afternoon, good morning with a good smile, my dear. I say the greetings, my dear. I say the greetings, introduction, instruction. These three important points is really important. So as you start with the good greetings, with a good morning, with a good afternoon, with a good smile. So this is the good greetings, my dear. And during that time that you wash your hands and then introduce yourself. And the introductions will be something like that. That you start with that. My name is Dr. Saha, one of the PACES candidate here today. And next is the instructions, my dear. Instructions means that I've been asked to examine your lungs. And what I'm going to do, a little bit description, that I'll have a very good look first. And then feel and tap on your chest. And then listen of your lungs, my dear. So if you feel any kinds of pain and discomfort, just let me know. I'll stop at that moment. This pain management, as I say, the pain, posture and positioning. So the pain management, position means, yes, for the respiratory system examination, you need to check a little bit like this, that this is 45-degree angle. And once again, the exposure, my dear, then you need to expose the gentleman. So you need to tell him that, yes, would you mind just put off your shirt for me, sir? Yes, my dear, this is very much important. These are the 6 important steps that you need to do before starting this one. And many times that if you do it, so it will be just next to nature. So you'll not feel that anything that you missed, my dear. So once again, I'm just recapping all them together, starting with the good greetings, my dear. As I said, the greetings, introduction, instruction, these 3 important points. And next is the pain, position and posture, my dear. So the 3 important points. Along with that, the most important thing is that while you are talking to the patients, you must look at the instructions together. So look at the instructions here that is written that the station 1 respiratory system, and this man has a history of the bronchial asthma, and examine his respiratory system. So I'd like to talk the instructions, my dear. Sometimes the instructions are very good clues to reach your diagnosis. It is written there, this man having the history of the bronchial asthma. And now also you need to examine the patient respiratory system. It doesn't essentially mean that this gentleman may have the asthma. Number 1, it doesn't essentially mean that the patient may have the asthma or may not be the asthma. So yes, this is another clue that you need to establish whether he has the asthma or not. But now why this gentleman admitted in the station 1 respiratory system, that you need to think about. Yes, my dear doctor, listen very carefully. Sometimes it happens that the instructions is given like that. This gentleman having the bronchial asthma now presented with the shortness of breath on exertion, and you need to examine this respiratory system. So having the bronchial asthma and having the breathlessness on exertion, so you need to think something else, some other diagnosis may be associated. We'll discuss later on, but at least that you can think about the asthma along with anything else that the patient may have, the diagnosis. My dear, listen very carefully. One of the important tips and tricks, the instructions that will guide you to make the diagnosis. What is that? The first of all, that you need to think about the bronchial asthma, strongly associated disorder. Yes, my dear doctor, the bronchial asthma strongly associated disorder, I call it the single diagnosis that you need to remember, EGPA, my dear. What does this EGPA really means? E for eosinophilic, G for granulomatosis, P for polyangiitis, my dear. Means the eosinophilic granulomatosis polyangiitis. Means the EGPA, and the name of the disease is Shastro syndrome, my dear. So you need to remember the strongly associated disorder, the bronchial asthma, the EGPA or the Shastro syndrome. But the EGPA itself is a mnemonics, my dear, so that you can remember all the diseases is strongly associated with the bronchial asthma. The first disease, the E stands for the EGPA, G for the GERD, my dear. GERD means the gastroesophageal reflux disease. And once again, the P for PAN, my dear. PAN for polyarthritis nodosa. And next one, A for, I call it ABPA. It's ABPA disease. It just means that ABPA means allergic bronchopulmonary aspergillosis. So these are the 4 important diseases that you need to remember. There is a bronchial asthma strongly associated disorder. It's an EGPA. So once again, E for EGPA, G for GARD, P for PAN, and the A for ABPA or ABPA disease, I call it. So here's the allergic bronchopulmonary aspergillosis. Another box that you need to know, my dear. The bronchial asthma strongly associated disorder, these are EGPA, but along with that, the bronchial asthma along with the significant eosinophilia, you need to know the first diagnosis, the EGPA, the second diagnosis, the ABPA, my dear. Once again, what I say, the bronchial asthma strongly associated disorder along with the eosinophilia, BA plus EO EROP, means the bronchial asthma with the eosinophilia. The first diagnosis is EGPA and the second diagnosis ABPA, my dear. ABPA means allergic bronchopulmonary aspergillosis. I'd like to talk a little bit more. Allergic bronchopulmonary aspergillosis diagnosing, my dear, that having the good diagnostic criteria. So I put the ABPA so that you can remember before handling this gentleman case, my dear. So if you know this theory fast before handling your patient so that you can understand the case, my dear. So let me start by the A for allergic. Allergic means that you need to remember the asthma, my dear, or bronchial asthma. So A for asthma, as I said. So you need to remember the A for allergic. The word will be helpful to remember the asthma along with the eosinophilia, along with the IgE, or means the significant serum IgE levels will be very, very high. So yes, my dear, what I say, A for allergic, the word, it will be remember, and you can remember the asthma with eosinophilia with the IgE, means the serum Ig level will be high, my dear. And next, the broncho, the word that will be helpful. The broncho means the bronchiectasis. Yes, my dear doctor, the broncho means bronchiectasis, so that you can remember. And the P for, yes, my dear, the pulmonary. So you need to remember the pulmonary infiltrates. Yes, my dear doctor, you'll get the pulmonary infiltrations in the chest X-ray. And you need to remember, this is very much important. The allergic bronchopulmonary aspergillosis is sometimes affecting the apical zones. A for apical zones, so that you can remember. So apical zones, the pulmonary fibrosis, they can affect it. And the next disease, as you said, the A for aspergillosis. So it does mean that aspergillosis, the evidences, if you can show them the aspergillosis, so that yes, you can make the diagnosis. ABPA means the A for aspergillosis. You need to remember aspergillus antibody should be positive, or maybe aspergillus, we call it this antibody, the aspergillus precipitans. And you can remember the another test that you can do, the RAS test, my dear. I call it the A for aspergillosis, A for AST, means the AST test, means the radio allergosorbent test, my dear, is positive. So as I say, the diagnostic criteria, the ABPA, so you need to fulfill this criteria to make your diagnosis ABPA. So as I say, the A for allergic, you need to remember the bronchial asthma, eosinophilia, Ig EROP. B for bronchiectasis, B for broncho means the bronchiectasis, P for pulmonary means the pulmonary infiltrates, and A for, once again, that you need to remember aspergillosis evidences by the aspergillus antibody, aspergillus precipitans, and aspergillus, once again, the rust positive, my dear. So these are the diagnostic criteria that you need to fulfill before making your diagnosis ABPA. So yes, my dear doctor, as already you learned how to approach the respiratory system before handling your patient so that you can reach your diagnosis. As I said, my dear, you need to go to the foot and bed and see the symmetry of the chest. As I said, the symmetry, epidiameter, Crackles, my dear. So these 3 important points, if you can remember, you can get the diagnosis. So if they get the symmetry, then the diagnosis you need to remember, once again, the COPD, bronchiectasis, pulmonary fibrosis. And then you come back here and you see the epidiameter is increased. So yes, the diagnosis will be the COPD and bronchiectasis. And next step, as I say, the Crackles, the word, if you found the Crackles, diagnosis bronchiectasis. If you found the Crackles absent, the diagnosis COPD. So once again, my dear, symmetry, epidiameter, Crackles. These are the important tips and tricks to deal with your case, my dear. Once again, if you found not symmetry, means the asymmetry, then you need to see the back on the chest to see the scar. So asymmetry with the scar, diagnosis lobectomy, pneumonectomy. Asymmetry with scar, lobectomy, pneumonectomy, and only the next point, the trachea, tracheal position, will give you an idea whether it's pneumonectomy or lobectomy. The approaches that you already learned, there is an asymmetry with scar, trachea. Now once again, the asymmetry without scar, the second and the third point is a Dallon percussions, my dear. So once again, asymmetry without scar, Dallon percussion, pleural effusion, pleural thickening, raised hemidiaphragm, and the next point is the consolidation, collapse, and cancer, my dear. So these are the things that if you know these three important pathways to reach your diagnosis before handling your patients, and just rehearse before entering the room so that you can make your diagnosis, my dear. So how to do that? Once again, recap and recapitulating all the points all together. So yes, once again, the symmetry, epidiameter crackles, asymmetry with scar, trachea, asymmetry without scar, Dallon percussion. Yes, my dear doctor, let me show how to do that onto this gentleman and get the diagnosis in your hands. So yes, my dear doctor, as you learned that the steps, my dear, that you need to do, so you need to expose the patients. So you need to tell your patients, sir, would you mind just put off your gown? Sir, would you mind to put off your gown or put off your shirt? Is it all right? I'll help you. Just so what do you need to do? You need to help the patient actually to put off the shirt. So yes, that means that you're really helpful to your patients and to help him in each and every regards, and also make your patients always comfortable state. So in each and every steps that you need to make him in a comfortable state of their, yes, and asking him in each and every point that, sir, are you comfortable?
Yes.
Thank you very much. And immediately after that, you start your examinations. So as I said, that you need to go to the foot in bed and tell him and to see the symmetry of the chest, my dear. How to do that? Just let me show. Yes, could you please turn your head on the left side? You need to tell him, and you need to come back like the way that I'm sitting here, and to see his chest, and tell him, take a deep breath in and out, all the way through your mouth. Sir, take a deep breath in and out. Once again. So you see that once again, you see that his chest is expanding less, definitely less than that of we expect. But his chest is moving, once again, yes, there's a symmetrical chest expansion. And the second important point that you need to ask him, sir, could you give a cuff for me? Yes. So what we are looking for, if you give a cuff for me, if you have the sputum, productive sputum, so that you can think about that maybe the bronchiectasis. But once again, coughing absent, it doesn't mean the bronchiectasis you excluded, my dear. So once again, the symmetry of the chest that you have seen, the making your diagnosis definitely the COPD, bronchiectasis, pulmonary fibrosis. And immediately after that, as I said, the symmetry that you have seen, then you need to come back here to see the AP diameter. So sir, yes, you need to see the way that I'm seeing, yes. His chest is AP diameter is increased. So definitely the diagnosis COPD and bronchiectasis. Now what you need? We need the Crackles, my dear. So keep in your mind that you need to make the Crackles positive so that you can say the diagnosis bronchiectasis. So symmetry, you found the AP diameter is increased. So diagnosis COPD and bronchiectasis. And now that you need the Crackles to make your diagnosis bronchiectasis. So yes, my dear doctor, you need to be very vigilant to look for the bronchiectasis. Now, before going to examine more, you will try to get the findings of the bronchiectasis, means the Crackles. But along with the Crackles, that what we are looking for? We are looking for, my dear, listen very carefully, the most important talk is a clubbing. If you found the clubbing, so yes, the diagnosis is likely bronchiectasis is the diagnosis. So bronchiectasis needs the clubbing, needs the Crackles. In these gentlemen, if you found them, so yes, this is the bronchiectasis, the case, my dear. So once again, as you found the AP diameter is increased, so definitely the COPD and bronchiectasis. And if you found now the clubbing only, the peripheral sign. So the diagnosis of bronchitis is more likely the bronchiectasis is your diagnosis. So the bronchiectasis needs the clubbing and crackles. And once again, the crackles will be the coarse crackle throughout the inspiration and expiration sometimes, but the coarse crackles, my dear. Coarse crackles throughout the inspiration. Once again, this is very much important, and these crackles is essentially diminished after coughing, means the changes after coughing. So these three important points that we need to fulfill so that we can make our diagnosis, the bronchiectasis. My dear, listen very carefully. What are the tips and tricks that we learn from the symmetry, COPD, bronchiectasis, pulmonary fibrosis? You come up here and to have seen the epidiameter increase, so you diagnose COPD and bronchiectasis. Now we need the clubbing. If you found the clubbing, so your diagnosis is definitely bronchiectasis. Now, immediately after that, you have to be very vigilant, keep in your mind that I have to confirm by getting the crackles, my dear, in my hands. And that should be the coarse crackles that you're expecting throughout the inspiration, and definitely after coughing, that will be changed. So yes, my dear, let me start by examining him more onto the hands examination first. So sir, could you please just do like this for me? Yes, do like this for me. So what I'm looking for the clubbing, my dear. This is very much important. So he has got a clubbing. Yes, he's got a clubbing. You see that all the fingers are clubbed. So he has got a clubbing. Yes, can you do like this for me? Yes, thank you. So you see the nail bed and nail angles are obliterated. So this is clubbing. If you're confused sometimes that you can do it, or if you're not confused that you just go ahead with this. Just the way they just show me your hands and then you see the... So my dear, one of the important tips and tricks, as I said earlier, if you got the clubbing, my dear, along with that, you need to look for the other bundle packs of the malignancy, means the cancer bundle packs that has to be excluded or maybe included whenever you found the clubbing is positive. You made your diagnosis clubbing, definitely. Along with the symmetry, epidiameter increase, and clubbing diagnosis made already the bronchiectasis. But now it's really important, my dear, what I'm emphasizing, whenever you found the clubbing, then you need to think and you need to exclude the cancer bundle packs altogether. As I said, the yes, the clubbing, and you need to see any nicotinic staining, or sometimes we call it the tar staining, my dear. So nicotinic staining. So as I said, the clubbing, nicotinic staining, and the wash. You need to remember, as I say, the clubbing, nicotinic staining, and the wash. These three in the hands and the bundle packs for malignancy or cancer bundle packs. Next, you need to go up, 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 and in the eyes there you need to look for the Horner syndrome. You need to look for the SBCO, and you need to look for the lymphadenopathy. These three, my dear. So once again, Horner's, SBCO, and the lymphadenopathy. Horner syndrome, once again, as I say, the SBCO means the superior vesical obstruction, and once again, it's really important that the lymphadenopathy. So here's the Horner syndrome, SBCO, lymphadenopathy. These three, along with these three hand findings, means the clubbing, nicotinic staining, and the wash. So once again, clubbing, nicotinic staining, wash, and the Horner syndrome, and once again the SBCO and the lymphadenopathy. These 336 points, my dear, you need to remember, and you need to exclude them. The cancer bundle pack. And in the middle of the chest that you can look for any radiotherapy burn marks also. These are the 7 important points for the cancer bundle pack. So yes, my dear, immediately after that, yes, just look at here to see the clubbing. And he has got the clubbing. So we are looking for the nicotinic staining. We are looking for the wash. So he has not wash and not having the wash. But turn your hands like this. And to see the next point here in the hands, my dear, to look the pulmonary edema. And to feel the warm hands. He has not the pulmonary edema. He is not having the warm hands. And to feel the pulse. To feel the bounding pulses. He is not having the bounding pulses. And once again, you need to do the flaps, my dear. Can you spread your fingers? Spread, 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 spread. Could you please cock up your wrist back for me? and you need to hold it, and once again you need to back pressure. So he doesn't have flaps as well. So yes, my dear, what I'm saying in the hands that you need to know the carbon dioxide retention findings, my dear. Carbon dioxide retention findings, it includes that the pulmonary edema, warm hands, as I said, my dear, once again, pulmonary edema, warm hands, and the bounding pulses. Pulmonary edema, warm hands, bounding pulses, and the flaps. These are the important points that you need to know, and you need to be very vigilant any of the features of carbon dioxide retention. These gentlemen having no pulmonary edema, not warm hands, not bounding pulses, not flaps. So no carbon dioxide retention. So yes, see the skin thinning. Skin is thin, very thin skin. So this is one evidence of the, you see the skin thinning, you see the skin thinning. 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 And this is one of the important steroid evidence at the bedside. S for skin, T for thinning. So the ST for steroid. So that you can remember, my dear. Immediately after that, we need to go up to look for, once again, the eyes. Look up for me to see the anemia. Look down for me, sir, to see the jaundice. Now stick your tongue out for me to see the anemia. Tongue up to see the jaundice. Once again, stick your tongue out for me to see the cyanosis as well. It's really important to see the central and peripheral cyanosis. So cyanosis you need to see in your hands as well. So he's not cyanosed as well. And also the lips, you need to see the cyanosis, and you need to see the gum hyperplasia. Can you show me your gum? So he has not the gum hyperplasia. So yes, my dear. So these are the negative things, that the peripheral things that you need to see. Once again, anemia jaundice, gum hyperplasia, along with the cyanosis. So yes, my dear doctor, as because you start with the symmetry, you found the symmetrical chest expansion is reduced, you come up here to see the epidiameter is increased, so your diagnosis is COPD bronchiectasis. Now you're waiting to get the crackles in your hands to make the diagnosis confirmed, that is the bronchiectasis. And also you found the clubbing, once again, that you made your diagnosis bronchiectasis having even touch on the chest proper, but you are looking for the crackles to confirm the diagnosis. As I said, that you need to have, whenever you found the clubbing, so you already excluded the cancer bundle packs altogether, because the malignancy is one of the important cause of bronchiectasis as well, and that will be the localized bronchiectasis, because a mass lesion block the bronchus, distal to the part, the areas will be the infections and obstruction, that leads to the bronchiectasis. So yes, my dear doctor. So what I'm saying, that we must to exclude the cancer bundle pack whenever you found the clubbing, my dear. Yes, my dear doctor, listen very carefully. Immediately after the peripheral examination that you already done, now we will be very vigilant onto the chest proper examinations. But once again, keeping our mind that we are looking for crackles. So that's why the tips and tricks that you need to examine the front of the chest very swiftly, then go back to the chest, so that you can get the findings on the crackles, my dear, you're expecting. Because the back findings will be the more and more prominent for the bronchiectasis, and you'll get the findings, my dear. So you need to do very swift onto the front. And the chest proper examination, the inspection, palpation, percussion, and auscultation altogether, but it needs that the CEP and BSBR, my dear. As I said, these four important things that you need to be very vigilant and comment on that. What does it mean? The CE for the chest expansion, PN for the percussion note, BS for the breath sound, and BR for the vocal resonances, my dear, and along with the air sound. But my dear, listen very carefully. You must remember that CEP and BSBR, as I said once again, CEP and BSBR. Once again, CEP and BSBR. So you need to remember so that you can focus and to get the findings all together. So the chest expansion, percussion note, breath sound, and vocal resonances, and the air sounds all together. And the CEP and BSBR, and top of them, yes, of course, the trachea that you need to see. As I said, whenever the symmetrical chest expansion that you found, so you don't need to worry about the tracheal positions, my dear. So yes, my dear doctor, the chest proper examination that will be started with the trachea. But as I said that you don't need to worry about the tracheal positions whenever you found the symmetrical chest expansion. So yes, you need to do the tracheal position just to do act that yes, the trachea is the central. So once again, sir, I'm just making it out so that the neck will be extended, and just hold it here and just put your hands like this, and this is the Adam's sepal, and this is the field that the trachea is the central. And insinuate your middle finger in between the sternocleidomastoid right side and the left side trachea and the right sternocleidomastoid. And you feel that this trachea is a central position, and the feel the trachea position is a central. So yes, immediately after that you found the trachea is the central, and you are expecting that one, so you don't need to worry about the tracheal positions, my dear, in this fashion. So what you need, my dear, this is very much important, that you need to, once again, as I said, the CEP and BSVR, means the chest expansion is the first step that you need to see. And you need to tell him, sir, could you please do like this for me? So that you can get the full chest in your hands, my dear, so that you can examine the patient. So what you need, that you need to place your hands on the apical zone and tell him to turn his head on the left side. Sir, could you please turn your head on the left side? And take a deep breath in. Once again. Yes. Now in the middle of the chest, once again, can you take a deep breath in? Once again. So his symmetrically chest expansion is reduced. Once again, onto the down. So his chest expansion is reduced symmetrically, bilaterally onto the both side. And immediately after the CE for the chest expansion, P and BSB, the percussion node is the next one. So you need to do the percuss onto the chest. And you need to tell them, I would like to tap on your chest side. So can you turn your head on the left side? So once again. So the sound is hyper resonant, you see, and over the clavicle here. So see. So here's the hyper resonant chest, and onto the axilla. Can you do like this for me, sir? And over the axilla. So here, over the axilla, over the axilla. So you need to compare on the both sides to see the bilaterally chest, means the percussion nodes are hyper resonant. So you found the chest expansion symmetrical, percussion node, the hyper resonant. So you are getting the findings are consistent with the bronchiectasis that you already thought about. So immediately after the CEPN and then the breath sound, my dear. So breath sound, that you need to take the stethoscope in your hands, and then you need to do that. And you need to tell the patients, my dear. So you need to start from the apical zone with bell of the stethoscope and the diaphragm with the total lung zones, my dear. Apical zone, mid zone, and the lower zones all together. So put the stethoscope like that way and tell him, sir, turn your head on the left side. No. Turn your head on the left side. So take a deep breath in and out. Once again, sir. Take a deep breath in and out. So now turn this one with the diaphragm. Now take a deep breath in and out. Once again. Once again. Take a deep breath in and out, in and out, in and out, in and out, all the way through your mouth. And you can see his breathing pattern. You see the breathing pattern. Breathing pattern once again. So this is nothing but a vesicular with the prolonged expiration. So you see the expiratory phase is longer. So definitely this is an obstructive airway disease, my dear. So vesicular with prolonged expiration, the findings that you found, my dear. So with the stethoscope that you're expecting, the vesicular with prolonged expiration. So you need to put the stethoscope in the same places that you already done for the percussion note. So you need to put the stethoscope once again to put in the different places. So take a deep breath in. Take a deep breath in. Once again. Once again. Once again. So what I'm getting, my dear, with the vesicular prolonged expiration, and I'm getting here and here the inspiratory crackles, my dear, the coarse crackles that I'm getting. And these crackles will be quantified onto the back when I examine. So I got the diagnosis in my hands that the bronchiectasis is because the symmetry, AB diameter is increased, clubbing, and the crackles. So confirmed diagnosis. Now I need to be very vigilant and also to confirm myself the diagnosis is bronchiectasis. So yes, my dear, immediately after the breath sound that you need to tell the vocal resonance, my dear. As I said, the C, P and B is BR, so the here is a vocal resonance. So yes, once again, you need to put the same places and say to the patient, would you please tell 99 for me? So sir, could you please tell 99 for me? 99.
99. 99.
Once again.
99. 99.
Once again.
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 99.
Thank you, sir. Thank you very much. So this is a vocal resonance that you need to know, you need to do, my dear. You don't need to worry about the vocal resonances. We do the vocal resonances only, not doing the tactile vocal parameters, because the tactile vocal parameters and the vocal resonances are representing the same findings, my dear. And in this case, that we are not getting and we are not expecting basically for the vocal resonances finding. So what I'm saying, my dear, this is very much important. The chest proper examination needs that CE, PN, BS, VR, my dear. Yes, my dear doctor, you already learned that the findings that you found, my dear. Immediately after that you finish on the front, then you need to the back examinations altogether. Once again, the C, P and BSBR altogether that you need to do. So sir, would you please just sit forward for me? Then I would like to examine onto the back of you. Is that all right?
Yes.
Thank you very much. So yes, my dear doctor, onto the back that you need to examine the patient. And you need to tell, can you do like this for me, and show him in that way. Like the way that I'm saying, sir, could you please do like this for me? Yes. So immediately after that, you need to examine onto the back, just so the C, P and BSBR, my dear. So C for the chest expansion, percussion note, breath sound and vocal resonances. So the chest expansion, once again, you already done the apical zone onto the front, so you don't need to do that. So the chest expansion you need to do. So yes, you need to do from here onto the back side. And tell him, take a deep breath in, sir. Once again. So see, the chest expansion is reduced symmetrically. Now onto the back, once again, take a deep breath in. See? So chest expansion is reduced. Chest expansion is reduced, you see? Yes. So immediately after the chest expansion, the breaths means the percussion note, my dear. You need to do the percuss like the way that I am doing. So you are getting the sounds, hyper-resonant sound on the percussion note. Immediately after the CEPN, next the breath sound. So take the stethoscope here and once again tell him, take a deep breath in and out. Once again. So I'm getting the vesicular with prolonged expiration. Once again. Vesicular with prolonged expiration, but I'm now getting a crackles once again. Take a deep breath in. So I'm getting the bibasal coarse crackles. Immediately after that you found the crackles, my dear, you need to quantify, is it coarse or is it fine? to the coarse crackles. Immediately after that you found the coarse crackles, that you need to see whether this is throughout the inspiration rather than the fine end inspiration. With the coarse crackles, my dear, is a bronchiectasis, is the fine crackles, is a fibrosis. End inspirated crackles is the fibrosis, with the coarse toward the inspiration, bronchiectasis. And changes after coughing is a bronchiectasis. No changes after coughing is a pulmonary fibrosis. So what are we looking and expecting in this case? We are expecting definitely the coarse crackles throughout the inspiration and no change and changes after coughing. So we need to do this maneuver and tell this gentleman to give a cough for me and to see is there any changes. Sir, once again, can you give a cough for me? Once again. Now take a deep breath in. So yes, my dear doctor, there is a slight changes after coughing the characteristics of the crackles, my dear, but he has got the typical coarse crackles. In real practical tips and tricks, my dear, if you found the coarse crackles, make your diagnosis bronchiectasis. The coarse crackles with the obstructive airways findings like the vesicular with prolonged expiration. Yes, my dear, with some expiratory rhonchi. But the most important talks is that he has the coarse crackles throughout the inspiration rather than end of the inspiration, and the slight changes after coughing, the diagnosis bronchiectasis. So we found all the findings that the bronchiectasis that we confirmed, my dear. And immediately after that, you need to do the same thing, the 99 for me for the vocal resonance, the CP and BSVR. So just tell him, sir, could you please tell 99 for me? 99.
99.
Once again.
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 99.
Excellent, sir. So immediately after that you finish my on to the back examinations, the CP and BSVR, immediately after that you got a chance to look onto the lymph nodes, my dear. And you need to feel the neck glands and you need to tell him, sir, I'd like to see the neck glands and feel the neck glands. Sir, I'd like to feel the neck glands. So you need to put your hands onto the anterior chain of the sternocleidomastoid and the posterior chain of the sternocleidomastoid and the supraclavicular nodes. As because, my dear, you found the clubbing, as I said, can you remember, you need to exclude the cancer bundle packs altogether. And one of the important cancer bundle packs is lymphadenopathy. As I say, the clubbing, nicotinic staining, wash, the hand findings, and after that, Horn syndrome, SBCO, lymphadenopathy. Those three findings and the radiotherapy burn marks the 7 important findings of cancer bundle packs. So you need to see the lymphadenopathy whenever the patient is sitting and after doing the chest expansion, percussion note, breath sound, and vocal resonance. The CEP and BSV are immediately after that, just you got a chance to see and to feel the lymph glands, my dear. And it takes only 3, 4, 5 seconds, my dear. And you formulate everything all together and tell him just lying back once again, sir, just would you please just lie back for me once again? And the way that always you try to make the patients comfortable, my dear. Means keep your patients comfortable and your attitudes and everything just like that, the way that you're really caring your patients, my dear. So immediately after the back examination that you come forward, my dear, once again, lie back the patients comfortable and saying him at least 2, 3, 4, 5 times while during and dealing with him to examine him. As because you're giving some of the uncomfortable, definitely. Sometimes lying and doing the front and forward, making forward. So a lot of things make the patients a bit of discomfort. So always tell him and asking him, are you comfortable, sir? So saying this word, it will make a good, comfortable environment with the patients, with the examiners, observing you. Yes, you are really a good candidate, my dear. Immediately after that you finish, the last one is really important, that we need to see the leg edema, my dear. So, sir, you need to come back here and just feel the hands for the leg edema And always ask, is it painful?
No.
And you have to hold it over the medial malleolus. And it's a slightly pitting edema is there. Slightly pitting edema. Slight pitting edema is there. So he has some of the pitting edema as well. Immediately after that, you finished, my dear, examinations. You need to give a good thanks to the patients. And showing your gratitude to your patients, my dear, and making once again a smile and saying some of the word that will be helpful to make the environment something like this. So let me show how to do that. Yes, sir. Now you take back the dress, right? So what you need to do, you just help him and give the clothes back immediately after the bell ring, that you stop to examine and make a good thanks to the patient's mind and show the gratitude in that way. Sir, thank you very much.
Thank you.
And you have done excellent and fantastic job for me today. Thank you very much, sir.
Thank you.
Yes. So immediately after that, you give the good thanks and also saying some of the important word that you have done excellent, you have done fantastic job for me today. And giving a total environment is fantastic. And that needs you, this fantastic word and fantastic vibes to the total environment whenever you come forward to the examiners to present your case. So that will be really helpful, my dear. Immediately after that, you finished all together and you need to wash your hands once again. And take the stethoscope in your hands. Yes, my dear. Not like this, the way it was. And you need to take the stethoscope in your hands, my dear, because the British peoples take it in a different ways. Yes. So yes, take the stethoscope in your hands and then come forward to the examiners, both of the eyes of the both examiners all together, and look the both of them and involve the both of the examiners together, and just having a good posture like this rather than like this, my dear. Having a good posture like this means that you are really a confident candidate, and whatever you're saying means that you are really a good and confident candidate. Yes, my dear, how to do that? Immediately after that, finish your examinations, you need to tell the examiners, sir, I would like to finish my respiratory system examination by doing the bedside spirometry and bedside arterial blood gas analysis test. Sir, I would like to finish my total examinations by seeing the observation chart, especially to see the pulse, temperature, respiratory rate and blood pressure all together and oxygen saturation. And I'd like to do the urine dipstick at the bedside to see the sugar, protein, RBC, nitrites. So yes, my dear doctor, immediately after that, maybe the examiner is asking you, what is your diagnosis, what is your presentation, and tell me the findings in a different varieties of the ways that the examiner is asking. But keeping in that mind and formulate your presentations earlier before coming to the examination hall, my dear, many times if you do practice. So that will be really helpful. So my dear, listen very carefully what the presentation and the important points that you need to include in your presentation skills. So you need to formulate what the points that you need to present your case, my dear, like the case of the gentleman. The first of all, my dear, as I say, this is very much important, your diagnosis, like the diagnosis that we made, the bronchiectasis here. And bronchiectasis is based on the most important point that you found, the symmetry, epidiameter, and the crackles and clubbing, my dear. These are the important points that you need to include the positive findings in favor of bronchiectasis. The second important talk, my dear, that you need to talk about the respiratory failure. Any evidence of the respiratory failure at the bedside that you're looking for oxygen dependency or maybe the carbon dioxide retention findings, as I said earlier. And third point, my dear, listen very carefully, the core pulmonary, the evidence by the leg edema. Yes, my dear, this is the third important point. And the fourth important point is really important. That is the patient, yes, the underlying etiology of the bronchiectasis. The etiology of the bronchiectasis, yes, my dear, this is really important. At least if you know or if you get some of the idea at the bedside, so you have to come up with this word. As because you have seen the instructions given this man having the history of the bronchial asthma, and you found the bronchiectasis. So the asthma bronchiectasis, what is your diagnosis? Think about it. So the allergic bronchopulmonary aspergillosis. So at least you can suggest and you can tell about some of the suggestive tests to confirm your diagnosis, what you thought about. And that is the way actually examiner is expecting, that you speak very sensible and you speak very smartly, you speak very the specialist ways of talk, my dear. So yes, formulating all them together, the fourth important point, the fifth important point, my dear, if there are any evidences of the treatment that gentleman is on at this moment, if you get something, so yes, you can add on them. Sometimes the bedside, some of the inhaler, some of the nebulization, some of the treatment tablets may be there. That's because he's an allergic bronchopulmonary aspergillosis, so maybe at the bedside, maybe some itraconazole tablets maybe at the bedside. So it will be a good clues, my dear. So yes, my dear doctor, this is very much important. So formulating all them together, making the diagnosis. As because you say the asthma as well. So the gentleman maybe is on steroid. So the steroid bundle packs that you need to include in your presentations, my dear. Any steroid evidences. So you need to tell them all them together, so that making them all the findings all together and presentations will be really palatable and impressive to your examiners altogether. So including the 5 important points, as I said, my dear, the first of all, the bronchiectasis, second one is the respiratory failure, third one is a cardiac failure with the core pulmonary, and the fourth one is the underlying etiology and allergic bronchopulmonary aspergillosis. And the fifth one is on treatment, is any steroid evidence at the bedside that you are looking for. Putting all them together, so you need to present your case, my dear. How to present, my dear? Just look at me and I'd like to show how to present, my dear. Just stand like and involve the both eyes of both of the examiners together and just present your case like the way that I am saying, my dear. Yes, sir, my clinical diagnosis of this gentleman is bronchiectasis, evidenced by bilateral chest expansion reduced bilateral symmetrical chest expansion, along with the obstructive airway findings evidenced by the vesicular with prolonged expiration with the AP diameter is increased in the barrel-shaped chest. Along with that, I found there is a clubbing. The fingers and the toes are clubbed bilaterally altogether. Along with that, I found the crackles, and these crackles are the coarse crackles throughout the inspiration, and there is a slight changes after coughing. So my clinical diagnosis of this gentleman is bronchiectasis evidenced by symmetrically reduced chest expansion with the increased AP diameter with the barrel-shaped chest, with the evidences of the obstructive airway disease evidenced by the best and the best and the best course ever you will experience in your whole life, my friend. Vesicular with prolonged expiration along with the crackles, the coarse crackles throughout the inspiration, and there is a changes after coughing, and there is a clubbing bilaterally, both the hands and both the face and fingers and toes all together. And this bronchiectasis is not complicated by respiratory failure at this moment, because I have not found any of the cyanosis. I have not found any of the features this gentleman is on oxygen dependent at this moment, because the bedside, no surroundings of the oxygen cylinder or maybe the oxygen cannula in situ or maybe the oxygen mask at the bedside. So as because this gentleman having no these features, so this gentleman having no features of respiratory failure and also no features of carbon dioxide retention in the forms of, as I say, the warm hands, pulmonary edema, bounding pulses, and also the flaps, my dear, altogether. And these gentlemen, the bronchiectasis is complicated by core pulmonary, as evidenced by, once again, the leg edema. So, but I would like to examine the cardiovascular system to get the features of pulmonary hypertension, the right heart failure altogether, to see the features of the core pulmonary. And also, I have seen these gentlemen having the history of bronchial asthma, As because of the history of bronchial asthma and he has got the bronchiectasis altogether, I think the underlying etiology of this gentleman bronchiectasis is allergic bronchopulmonary aspergillosis. And this gentleman is on steroid, as evidenced by, as I said, the S for skin, T for thinning, my dear. The skin thinning is a single evidence at the bedside. So that you can say this gentleman is on steroid. So let me show the skin thinning. So you see, this is the skin, and you see the skin thinning here, and the best areas that you can see the skin thinning is skin thinning. His skin is thin enough, so he's on steroid. So putting all them together, my clinical diagnosis of this man, of this gentleman, is bronchiectasis complicated by cold pulmonary without evidence of respiratory failure, and the underlying etiology of the bronchiectasis is allergic bronchopulmonary aspergillosis, and he is on steroid at this moment. So, I'd like to confirm my diagnosis by sending the Aspergillus antibody and Aspergillus precipitans, and as well as the rust test to Aspergillus. So yes, I'd like to confirm also the bronchiectasis to do request to the HRCT chest, and that includes the signet ring appearances of the bronchiectasis. And I'd like to test the other blood tests, especially I'd like to look at the complete blood count that will give me the idea of the eosinophilia, significant eosinophilia. And I'd like to test for the serum IgE levels. And also along with that, a simple test, that is a chest X-ray, that will give me the idea of some of the pulmonary infiltrations. So putting all them together, that I'm expecting that the bronchiectasis, confirming the diagnosis by doing the HRCT test, and along with that, I can do the pulmonary function test as well. That will give me the idea of obstructive lung defect that will be evidenced by FEV1, FVC ratio less than 70%. Usually the examiner is asking, what is the treatment and management plan that you should do this of the gentleman? As because I made the diagnosis, the allergic bronchopulmonary aspergillosis, my dear, is you need to know, this gentleman needs the steroid for the treatment of acute attack of any shortness of breath or exhaustion, wheezing, for the bronchial asthma. And also for the aspergillosis, that the patient should be put on for the long-term antifungal treatment, that is itraconazole. And that will be the treatment management. Along with that, definitely that we need to think about because of bronchiectasis, my dear. So you need to tell to your examiner, sir, I'd like to put this gentleman on some of the general measures and some of the specific treatment, as well as some surgical treatment if he needs. The first of all, the general measures that includes the smoking cessation, and second thing, the oxygen therapy if really he needs. And the third thing is really important for the vaccination, especially the influenza and pneumococcal vaccinations. And fourth thing is the antibiotics if there is any evidences of infection. And fifth thing is the bronchodilators if he has any of the evidence of the bronchospasm. So these are the 5 important points of the general measures. And once again, the specific measures and the specific treatment of this gentleman for the bronchiectasis is a long-term antibiotic therapy. It's really important. The long-term antibiotic therapy can be given by oral treatment, or maybe sometimes the nebulizations, the treatments are available. And along with that, the most important thing is the expectorant, my dear, cough expectoration. And that can be done by giving some of the mucolytics and maintaining his hydration as well. And third thing sometimes that we use that the N-acetylcysteine as well. So these are the cough expectorant, and the most important top of them, we need to train the physical training, and the physiotherapy will be helpful, the chest physiotherapy, to expectorate the more and more sputum. So yes, my dear. So along with these 2 important specific treatment with the long-term antibiotics, and along with that sputum expectoration, and that can be done best by the physical training and physiotherapy, chest physiotherapy. And these 2 specific treatment and the surgical treatment, yes, if he really needs, that the surgical treatment may be needed sometimes. So these are the ways that you need to present your case, and you need to tell how to investigate and to confirm your diagnosis, and what will be the long-term planning as well for the management plan altogether, and impress the examiners altogether. So I would like to show this gentleman having the diagnosis of the allergic bronchopulmonary aspergillosis, and this is an evidence-based. That is not needed for your exam, but at least if you see them, yes, this is a reality that comes at the end of the point. That is the diagnosis of the allergic bronchopulmonary aspergillosis. So I'd like to show some of the evidences here so that you can see and believe in yourself how to make the diagnosis, and really in the PACES exam, how the things can be applied and the knowledge can be applied confidently, my dear. Just come forward just to see some of the reports. I have got the reports here, the serum Ig level, and also there's a pulmonary function test, and the treatment is given, and after treatment the serum aspergillus antibody getting down. That I'd like to show this one. So yes, the gentleman, as I said earlier, the allergic bronchopulmonary aspergillosis. So A for allergic, so A for asthma, and eosinophilia, and also the serum Ig level. So you see the serum Ig level is more than 100. It does mean that more than, yes, 1000. You see the 100 is the lowest limit, yes, more than 15 plus is less than 150. But you see this is 1162, means the more than 1000 is a very significant, very high serum Ig levels. So we got the single point to diagnose is the asthma, eosinophilia with the serum Ig very, very high. And once again, this is because of the asthma, definitely the asthma, but along with the bronchiectasis, the allergic bronchopulmonary, the bronchiectasis, the next point that we have done the test for the pulmonary function test, and we found the pulmonary function test that showed that you see the FEV1-FBC ratio, FEV1-FBC ratio is 61%. You see the 63% is the 61% here. 61, you see. So yes, this is the mild obstructive abnormality. So this is the mild obstructive abnormality. So this is very much important. So once again, then you can understand that is the obstructive airway disease. So other than these two, that we already made the bronchiectasis and also the allergic bronchopulmonary aspergillosis. So as because we found the allergic broncho means the obstructive airway disease, and now that we done the serum aspergillus antibody, and that was very, very high earlier, and provided the serum aspergillus antibody is very, very high, and we started the treatment with the ITRA. You see the capsule itraconazole, that is ITRA 100 milligram once in 4 months. So the patient is taking already this treatment after diagnosing the serum aspergillus antibody, and after treating the patients, we got the reports here. You see the serum aspergillus antibody is getting down, is less than 8, is normal, is 1.62. So these gentlemen are having a very good response with this. The previous report, the gentleman is lost it, so that's why we couldn't show it, but it was very, very high. But after treatment, you see these gentlemen, yes, you see that this is the 11th August, 21 August of this 2019, and this is the 18 February of 2020. So after having good treatments with the itraconazole and with the steroid, these gentlemen having very good response with the IgG, serum IgG, means the aspergillus antibody is getting down, is getting normal. So the diagnosis, allergic bronchopulmonary aspergillosis. So here's the allergic that we got the evidences here, that the serum Ig level is very high, bronchiectasis, obstructive airway disease, there is a obstructive lung defect in the pulmonary function, and after treatment with itraconazole, that we found that the treatment means the serum Ig antibody is getting down, is good responding. So diagnosis, allergic bronchopulmonary aspergillosis. And of course, for the bronchiectasis, we need to do the HRCD test. Maybe we can show you the HRCD test, the reports altogether, my dear.